Okay, and then the other topic is the Alzheimer's disease. Okay, so in Alzheimer's disease, you should know the etiology, clinical features, and morphological features. Okay, so actually from the CNS, so in from exam point of view, usually will be asked the questions on the meningitis, intracranial hemorrhages, and tumors of the brain. Okay, sometimes brain disease, it might be asked, but the important topics from the CNS that are the meningitis. Okay, they will ask it asks you in long questions or short questions. Similarly, the classification of intracranial hemorrhages, and the other one topic is the CNS tumors. Okay, and this Alzheimer's disease. Okay, so actually this first we'll start with the classification of the degenerative brain disease. Okay, so what do we mean by the degenerative brain disease? Okay, so the definition starts like it is a disease of gray matter. So it is a disease of gray matter characterized by progressive loss of neuron. Okay, so there is the loss of neuron, and that is associated with the secondary changes in the white matter tract. Okay, so degenerative diseases of the brain are the disorder of the gray matter that are characterized by progressive loss of neurons with associated secondary changes in the white matter tract. Okay, so that defines the degenerative brain disease. Okay, so it is characterized by progressive loss of neurons or their systems. Okay, so the basic thing that occurs in the degenerative disease is the loss of neurons. Okay, so that the degenerative disease can result in dementia or the severe motor impairment may occur. Okay, so depending upon the condition, some patient may have the dementia in the later stages, they may have the motor impairment as well. Okay, so what is the term dementia? Okay, so dementia is nothing but that is the loss of memory or language or problem solving or thinking capacity of the individual. Okay, so loss of all these things like the loss of memory, language, okay, problem solving, thinking, that would that would result in problems in the personal daily life and activities. Okay, so once there is loss of, if you have loss of memory or if you have loss of language, if you have we all human beings, okay, actually the normal human beings, we all have this capacity. We have this capacity. Okay, so once there is the loss of memory, language, problem solving, so all these things occurs, then definitely we'll have a problem in our day-to-day activities. Okay, so dementia is nothing but the loss of cognitive function. Okay, and the behavior abilities. Okay, so um, that would create a problem in our daily activities. Okay, so cognitive function means the person's ability to process the thoughts. They have learning, solving problems. We have a normal cognitive function. That means we can think, we can remember, we can reasoning. We can do the degenerative disease. The person's usually it needs. So, disease etiology, there are so many degenerative diseases that are classified. Today we'll be focusing on the Alzheimer. There may be the presence of protein aggregates. Okay, and one of the etiology for degenerative disease is there is the presence of the protein aggregates that are resistant to degradation through ubiquitin proteasome system. So there is the presence of the protein aggregates and these aggregates. Okay, so these protein aggregates, okay, we can see microscopically. Okay, these aggregates, okay, if you see on the slides, we can recognize them as inclusions. Okay, so inclusions are nothing but these are the protein aggregates with resistance to degradation. So you can see those protein aggregates inclusions. Okay, and basis for aggregation varies across disease. Okay, so Now, various protein aggregates, okay, that vary according to different degenerative disease. Okay, so the basic thing in degenerative disease is that there is a progressive loss of neurons that will result in dementia and in motor impairment. Okay, and in etiology, you see the presence of the protein aggregates, and you can recognize them as inclusions. Okay, so see, the degenerative disease may be directly related to. Okay, so an intrinsic feature of like the progressive loss of neurons or their systems. Okay, and it is neurodegenerative impairment. Okay, so what is dementia? So it is a loss of memory, okay, language, problem solving, and thinking capacity of an individual. Okay, so these are all their us. Okay, so we can think, we can remember, all hormone. Okay, so once there is the loss of cognitive function, okay, so like loss of memory, language, problem, okay, so that was a problem in our today activities. This actually the person suffering from this disease have a dementia and they have a severe motor impairment. Okay, so actually in this disease there is a loss of cognitive function. So cognitive function is nothing but it's a personal ability to have a process thought, like okay they can learn and problem solving, they can do thinking, reasoning, okay, and those things. Okay, so basically degenerative disease, memory and cognitive impairment. Okay, and in some cases there may be preserved normal level of consciousness. In severe patients, in severe degenerative diseases, not only they have a memory and cognitive impairment. In the later stages, they may have a loss of consciousness. Okay. So in degenerative disease, basically in most of the degenerative disease, there is a presence of protein aggregates, okay, that are resistant to degradation through ubiquitin proteasome system. Okay, so in the basic thing that you have to understand in degenerative disease is there is the aggregation of protein aggregates. There is the presence of protein aggregates. Okay, and these protein aggregates can be seen microscopically on the slides as a inclusions. Okay, so the basis of aggregation varies across disease. Okay, so that we'll be talking later. So in pathogenesis, okay, so the degenerative brain disease may be directly related to, okay, so one in an intrinsic feature of mutated protein. Okay, so there may be the mutated protein, okay, like in case of Huntington disease, there is a polyglutamine repeats. Okay, the mutated protein is the polyglutamine repeats, okay, that you will find in Huntington disease. Similarly, the other that we are studying today is the Alzheimer's disease. Okay, so in this case, there is a peptide derived from larger precursor protein. Okay, beta amyloid, that protein that is aggregated in the Alzheimer's disease. Okay, and similarly in the Parkinson disease also we'll be talking in our next lecture. Okay, so see, in this case there is an unexplained alteration of normal cellular protein. So see, in this case there is a presence of alpha synuclein in sporadic Parkinson disease. Okay, so the classification of the degenerative brain disease, that is based on the location. Okay, so based on the location, the degenerative disease can be classified as, you see, the Alzheimer's disease. In this case, there is the degeneration of the cortex. Okay, if there is degeneration of the basal ganglia and the brain system, we classify it as a Parkinson disease. Okay, and in ataxia, so there is the degeneration of the spinocerebral tract that will result in ataxia. So what is ataxia? Okay, so actually the ataxia is the loss of coordination of the voluntary movement. Okay, so the patient has a problem in doing normal things like walking, they have a problem in speech, even in swallowing. Okay, so actually ataxia is the loss of muscle control. And the motor that that degeneration of motor neurons occurs in muscle atrophy. Okay, so this is the classification based on degeneration of the cortex, Alzheimer's disease, degeneration of the basal brainstem, Parkinson's disease, degeneration of the spinocerebral ataxia, degeneration of motor neurons. Okay. So we have other classification. Okay, so that is based on the clinical features. Okay, so um, so in one classification, okay, there is the memory disorder. Okay, so that is the Alzheimer's disease. Okay, similarly, memory disorders that can occur in Parkinson disease as well. Okay, and frontotemporal disease that also comes under the memory disorder. And the other is the disorders of the movement. Okay, so one is Huntington disease, other is Parkinson disease, progressive supranuclear palsy. Okay, so these all comes under this. Okay, this class will be just focusing on the Alzheimer's disease and Parkinson's disease. Okay, for your label. Okay, and the other is the motor neuron disease. Okay, that includes spinal muscular atrophy and amyotrophic lateral sclerosis. So these are the motor neuron disease. Okay, so there is also another classification. Okay, that this is a broad classification. Okay, that depends on the presence of the inclusion. Inclusions are nothing but these are the aggregates of proteins, and if you see on the microscope or on histology slide, we see as a inclusions. Okay, so we'll be talking about Alzheimer's disease. Okay, so we'll be talking about the neuritic plaques and the tangles in the. Okay, so these are the inclusions. Same thing for Alzheimer's disease. Alzheimer's disease, see, you have a main clinical feature is dementia. And other is the frontotemporal lobar degeneration. In this case, a type of neurodegenerative disease, patient has behavioral changes, language disturbances. And in other, that is Parkinson disease, have a hypokinetic movement disorder. Okay, so hypokinetic, as such, it means it is the little movement. The term is hyperkinetic movement. Okay, so hyperkinetic movement, that means that excessive abnormal hyperkinetic, that means the little. So in Parkinson's disease, we have a hypokinetic movement disorder, whereas in cases of Huntington disease, we have a hyperkinetic movement disorder. Okay, similarly, there is progressive supranuclear palsy. See, in these cases, patient has Parkinsonism with no abnormal eye movements. The term is corticobasal degeneration. There is Parkinsonism with asymmetric movement disorder. multiple system atrophy, there is Parkinsonism, cerebral ataxia, autonomic failure. Okay, so and similarly in amyotrophic lateral sclerosis, okay, the patient may have weakness with upper and lower motor neurons. Okay, so they have features of upper motor and lower motor neurons weakness. Okay, so there is the spinal bulbar muscular atrophy. You may have lower motor neuron weakness. Okay, so these are basically some neurodegenerative disorder. Okay, so but we will be focusing on Alzheimer's disease and Parkinson's disease. Okay, so we'll start with our topic, that is the Alzheimer's disease. Okay, so the basic thing that occurs in Alzheimer's disease is the dementia. Okay, one criteria for Alzheimer's disease is dementia. Plus, is my voice still breaking or is it clear now? Do you have a problem?
अलिअलि ब्रेक भइरहेछ नि
You. Is it okay? Break भएको छ?
अलिअलि भएको छ म्याम
अलिअलि भएको छ? नेटकै साइडमा आछु है. ओके. अहिले पढाउँछु, इन केस केही प्रब्लम भयो भने नेक्स्ट क्लासमा भन न त है. स्लाइड पनि हेर. अलमोस्ट मैले स्लाइडमै भएको कुरा भनि नै राखेको छु. एन्ड saying the things that are on the signs. Okay, so actually this Alzheimer's disease. Okay, so it's birsane roog bhancha ni. Okay, so usually the older generation people may have the Alzheimer's disease. Okay, so so first I'll talk something and then I'll give some examples of Alzheimer's disease. Principally as dementia. Okay, which is a progressive loss of cognitive function independent of the state of attention. So the basic principle that that is there in the Alzheimer's disease is the dementia. So most common cause of dementia in elderly. Okay, so see the patients suffering from Alzheimer's disease, they are rare before 50 years of age. Okay, and that the incidence of the Alzheimer's disease increases with the age. Okay. So in the figure, we can see a healthy brain, okay, and in the other side, we can see the Alzheimer's disease. So in Alzheimer's disease, we have widened sulci. Okay, so that will be talking. In simple term, this is nothing but the birsane roog bhancha ni, that is the thing. Okay, so can anyone tell me? There are some actors, sports person, okay, they are suffering from disease and dementia. A few well-renowned actors, sports person, they will be suffering from this kind of diseases. Okay, so can anyone give me the example? सुनेको छ Alzheimer's disease भनेको? Okay, so तिमीहरुको voice चाहिँ मसँग आइरहेको छैन. Okay, so I'll tell. Okay, so actually medicine ma gayeपछि पनि you have to know about this Alzheimer's disease. Okay, so clinical medicine ma jab you will be posted. Okay, then you again study Alzheimer's disease as well. Okay, so there are some actors like Robin Williams, okay, James Johan. There are some persons, these are the actors, okay, suffer from Alzheimer's, and there are some sports person, famous football, okay, Tom Fears, that he also suffered from Alzheimer's. Okay, there are actually I forgot those name. Also name. There are some famous celebrities that suffer. So age group, these have onset at 50 years of age. Okay, and the incidence of the disease rises with age. Okay, and see the prevalence doubles every 5 years. And so the most cases are sporadic, 5 to 10% are familial. Okay. And some of the studies shows that Alzheimer's disease occur more among relatives. Okay, and see a clear inherited pattern of Alzheimer's disease exists in less than 10% of cases. Okay, and among these also around 40% are inherited as autosomal dominant. And see, there is an amyloid precursor protein gene, okay, that is in chromosome 21, that is implicated in occurrence of Alzheimer's disease. Okay, in cases like the persons with Down syndrome patient who survive beyond 40 years, okay, so person with a Down syndrome may develop Alzheimer's disease if he or she survives beyond 40 years, okay, and some families with a history of early onset Alzheimer's disease. Okay, so and similarly, Alzheimer's disease can occur if there is a mutation in presenilin 1 gene that is located on chromosome 14. Okay, and other is apolipoprotein E isoform. Okay, that also promotes beta amyloid generation. And sporadic. We have discussed in earlier slide also 5 to 10%. So the basic thing in Alzheimer's disease is the abnormal enzymatic cleavage of amyloid precursor protein that is known as APP. So abnormal enzymatic cleavage of amyloid precursor protein that results in the deposition of beta amyloid. Okay, and similarly, okay, if there is an apolipoprotein, okay, isoform promotes beta amyloid generation and its deposition. Okay, although the mechanism is that. So all these things that leads to deposition of beta amyloid. Okay, and what happens is with this there is a deposition of the beta amyloid. See, in these cases, once there is deposition of these things on the neurons, there will be altered neurotransmission. Okay, there will be toxicity for neurons and synapses. Okay, not only that, okay, local inflammatory response also occurs that will further lead to neuronal injury. Okay, mechanical effects and axons and dendrites occurs. Okay, and the other thing in Alzheimer's disease is there is the hypophosphorylation of tau protein. Okay, that and its redistribution and aggregation occurs that would lead to neuronal dysfunction and death. Okay, so while studying the morphology, we'll be talking about the tau protein, okay, neurofibrillary tangles, okay, so that we'll see in the slides in our upcoming slides. Okay, so evidence suggests a central core for a beta peptide in Alzheimer's disease pathogenesis. Okay, so amyloid plaques are primarily composed of A beta peptides, okay, which are produced by cleavage of amyloid precursor protein. And the mutation in this amyloid precursor protein that will lead to overproduction of insoluble amyloid peptide, okay, and because of its deposition, okay, that will result in neuritic plaques. So now the clinical features. Okay, so clinical features, Alzheimer's disease patient like okay, so serious impairment of higher cognitive functions. Okay, so the patient in the initial phase, patient may have lots of short-term memories, like let's say he or date of birth he might not know. Okay, so as a day or which month in the initial phase, like those kind of problems. Okay, so patient those kind of problems. Okay, loss of recent memories. Okay, so the patient may have a problem with the thinking and problem solving. The patient may have a so in the later phases, okay, so the patient may be disoriented, have a complete memory loss, patient may have maybe aphasia. Okay, see in the later last stage, patient may be immobile. Okay. So in the initial phase, okay, सानो सानो कुरा याद हुँदैन, सानो सानो काम गर्न सक्दैन. Okay, अनि then in the सुरु सुरुमा आफ्नो सानो सानो कुरा जस्तै त्यस्तो याद नहुने हुन्छ. Later the patient has a disorientation, memory loss, aphasia, and immobility. Okay, so progressive disorientation, memory loss, aphasia becomes manifest, indicating severe cortical dysfunction. Okay, so eventually in 5 to 10 years, the patient profound disabled, mute, and immobile. And so patient may be last month disabled, mute and immobile. Okay, so sometimes the patient may even die from the like the intercurrent infections like bronchopneumonia. Okay, so okay, so there was a problem in the sound. Okay, so पहिला चाहिँ पेसेन्टलाई he or she might have a problem in small things. Okay, so sometimes patient के हुन्छ घर जान्छ घरको बाटो आउन बिर्सिन्छ. ओके, त्यस्तो सानो सानो कुरा सानो सानो मेमोरीहरू कुरा हुन्छ. पेसेन्ट हेज अ प्रब्लम होइन, अनि उसलाई अब कतिवटा वर्ड्सहरू उसलाई भन्न आउँदैन, वर्ड्स नै बिर्सिने बानी हुन्छ, बर्थडे बिर्सिन्छ होइन. इन द लेटर स्टेज के हुन्छ, पेसेन्टले आफ्नो रिलेटिभ क्लोज रिलेसन हस्बेन्ड वाइफ आफ्नो बच्चा बच्ची त्यस्तो पनि चिन्दैन. ओके, अनि इन इन अब इन द लेटर फेजेस अब उनीहरूको इन द लङ टर्म के हुन्छ, सबै नै मेमोरी लस हुन्छ होइन. कसैलाई आफ्नो फ्यामिलीलाई नचिन्ने, खान नआउने, कुक गर्न नआउने, बोल्न नआउने, अनि पेसेन्ट द्याट मे बी इमोबाइल होइन. द्याट इज अ worst thing, you know. So that are the clinical features of Alzheimer's disease. Okay, so so actually there are, if you, I think I have seen two Korean movies. Okay, that had this that actor or actress I forgot as a Alzheimer's disease. Okay, so as it is a Friday, but want to know more about Alzheimer's disease, okay, you can see some movies. Okay, so you can see those movies. Okay, so that you'll know more about the Alzheimer's disease. Okay, so now the signs of Alzheimer's disease. Okay, so the same thing I am repeating, that the patient may have a memory loss. Okay, so once there is memory loss, that will obviously disrupt daily life. Okay, lifestyle. Okay, so the patients may have challenges in planning or solving problems. Okay, similarly patient may have a difficult completing familiar tasks at home work. Okay, so जुन हामीले डे टु डे काम गरिरहेको छ नि, जुन तिमीहरू स्कुल कलेज आउँछौ पढ्छौ, यो क्लास पछि यो भनेर बुक झिक्छौ, त्यस्तो हुन्छ नि, त्यो नै हाम्रो जुन डे टु डेमा गरिराख्ने एक्टिभिटिज नि, they will have a difficulty in performing those things. Okay, so see, the patient may have confusion with time or place, you know. Patient have a trouble understanding visual images. They have a problem standing the relationship with the family members, new problems with words in speaking or writing. Okay, because of that the patient may be mute in the later stages of life. Okay, similarly misplacing things and losing the ability to retrace steps. Okay, decrease or poor judgment. Okay, finally patient may have a withdrawal from the work or social activities. They will be withdrawal from the family members. Okay, change in mood and personality. Okay, so there are so many things that are basically related with the loss of memory, language, problem solving, thinking. Okay, doing small tiny things in the initial phases patient may have a, so they may be mute in. So these are the things that are seen in the patient suffering from the Alzheimer's disease. Okay, so in morphology, you have a cortical atrophy. Okay, so there is widening of the sulci that affecting the frontal, temporal, and parietal lobes. Okay, similarly, there is a compensatory ventricular enlargement that is due to the secondary to loss of parenchyma and reduced brain volume. Okay, similarly, the structures of the medial temporal lobe, including hippocampus and amygdala, are involved in the early course and may be severely atrophied in the later stage. So the basic thing is this morphology, just remember that there is a cortical atrophy and there is widening of the sulci and there may be compensatory ventricular enlargement. Okay, so this is the, in one figure there is a healthy normal brain, and in other left hand and in the other side you can see that there is the brain, okay, in which the sulci are widened. Okay, so in morphology, okay, so in microscopy or in histology, you'll see the presence of neuritic or senile plaques. Okay, so these are the two things that you shouldn't forget. Okay, so on histology, you see the neuritic plaques. One is the plaque, other is neurofibrillary tangles. Okay, and along with that, you have a in the initial phase. I have said that in degenerative disease, you have a neuronal loss. Okay, so there is presence of neuritic plaques, neurofibrillary tangles, severe neuronal loss. Okay, and not only that, there is a reactive gliasis. Okay, the surrounding areas may show the surrounding parenchyma, so reactive gliasis. So neuritic plaques, neurofibrillary tangles, neuronal loss, and reactive gliasis. So what are neuritic plaques? Okay, so the neuritic plaques are focal spherical. So these are the spherical collections of what? That are the collections of the neuritic processes. Okay, so the focal spherical collections of the neuritic processes are neuritic plaques. Okay, and these are usually found around a central amyloid core, which may be surrounded by a clear halo. Okay, so neuritic plaques are nothing but these are the focal spherical collection of dystrophic neurites, and they are found near a central amyloid core. Okay, so the sites where you can see the neuritic plaques are hippocampus, amygdala, and neocortex. Okay, so the amyloid core is A beta, okay, a peptide that is derived through processing events from a larger molecule, amyloid precursor protein. Okay, so this amyloid core can be stained by conborate. Okay, so the thing that in neuritic plaques are the focal spherical collection of the dystrophic neurites. Okay, so in the image, okay, you can see the neuritic plaques. Okay, and in the second image, you can see these are stained. Okay, they are stained with special stains, so you can see the neuritic plaques. So the other is the neurofibrillary tangles. That was plaque, neuritic plaque. Other thing that you see in the histology, the neurofibrillary tangles. Okay, so these neurofibrillary tangles are composed of eight helical filaments. Okay, so these tangles are nothing but these are the helical filaments which are abnormally hyperphosphorylated form of protein tau. Okay, so neurofibrillary tangles means the hypophosphorylated protein tau. Okay, that are seen as a filaments. Okay, so these are the neurofibrillary tangles. Okay, and this the protein tau is an axonal microtubule associated protein that enhances microtubule assembly. Okay, so the neurofibrillary tangles are the hyperphosphorylated protein tau that can be seen as a helical filaments. Okay, that are seen within the cytoplasm. Okay, they may be around the nucleus or they may push the nucleus. Okay, and the components in these neurofibrillary tangles are IP. Okay, microtubule associated protein and ubiquitin. Okay, but just remember that neurofibrillary tangles are nothing but these are the hypophosphorylated protein tau. This is a thing that you should know. Other composition that you may forget, that's okay, but don't forget about the hypophosphorylated protein tau. That is the core of the neurofibrillary. So neurofibrillary tangles are bundles of filaments. Okay, is the hypophosphorylated tau that is seen in the cytoplasm of the neurons. Okay, so that may displace or encircle the nucleus. And this, if you see in HNA stain, you will see the basophilic bluish tinge. Okay, fibrillary structures on HNA. Okay, and these neurofibrillary tangles are insoluble and apparently resistant to clearance in vivo, thus remaining visible on tissue section as ghost or tombstone tangles after the death of a parent. Okay, so actually what happens, these are insoluble and while in the processing in the tissue section. Okay, what you see, sometimes you see like ghost-like appearance. Okay, of these tangles, ghost-like appearance of um, thing that you see in the cytoplasm of the neurons. Okay, so what is tau protein? Tau is a neuronal microtubule stabilizing protein. It contributes to axonal transport, growth, and morphology. Tau misregulation and deposition that will correlate with the neuronal death. Okay, so tau protein that you'll not only seen in the Alzheimer's disease. Okay, you see those in the frontotemporal dementia and Parkinsonism as well. Okay, so But to diagnose Alzheimer's disease, okay, you have to see the clinical sign and symptoms. The one thing is that you have to do a detailed history, okay, and then while looking at the microscope, okay, you can see that there is presence of the neuritic plaques, okay, you see the neurofibrillary triangle, that is tau protein, you might see the surrounding areas, reactive glial cells, okay, and neuronal loss as well. Okay, so really diagnosis matter the microscope you can't classify or basic diagnosis that the patient is suffering from Alzheimer's. You have to look for so. So this is the figure, the first figure, that is the normal. You can see the neurons in the second figure. Okay, within the neurons. So please see, you can see the filamentous-like things. Okay, these are the neurofibrillary triangles, and in extracellular areas outside those neurons, you can see the deposits. Okay, these are the spherical deposits of the neurons. Okay, so you can see these are the amyloid plaques. So one of the thing that you see in the cases is the histology is the, you can see the so other things that you can see in patients suffering from Alzheimer's disease is you can see the amyloid deposition in the small vessels. Okay, so we have talked about the cerebral amyloid angiopathy and other things like granulovacular degeneration. Okay, so that is nothing but it is the formation of small clear intraneuronal, okay, cytoplasmic vacuoles, each of which contains an neurophilic granules. Okay, so the name itself, granulovacular, you have a small intraneuronal vacuoles that have a granule. Okay, so that may be seen, okay, in not all cases, but in some cases. Nothing but it's an elongated glassy eosinophilic body consisting of paracrystalline arrays of beaded filaments, okay, with acting as a major component. Okay, so you can see eosinophilic glassy bodies. Okay, so these are the hirano bodies. Okay, so actually in Alzheimer's disease, okay, you just don't forget about the neurofibrillary triangles and the amyloid plaques. Okay, in earlier granulovacular degeneration, hirano bodies, but these are the two things. Okay, and not only that, okay, the clinical features and symptoms. Okay, patient ko history, I know that is the main thing. Okay, so for that the essential criteria for Alzheimer's disease is the dementia. Okay, there will be the loss of cognitive function. Diseases of the brain, you should be able to classify, and then you have to write about the etiology, clinical features. Neuritic canine plaques. So these plaques figure these are actually extracellular. These have a amyloid core. Okay, these are nothing but the spherical aggregation of dilated and tortuous neurites. Okay, that are also the dystrophic dendrites. Okay, the spherical aggregations of the dystrophic dendrites are the neurons plaques. In the surrounding areas, you can see reactive microglia and astrocytes, reactive glial cells. Okay, so and the other thing about neurofibrillary tangle is they are usually intracellular. Okay, these are the basophilic fibrillary structures. Okay, they can encircle or displace the nucleus. Actually, these are the phosphorylated protein. The patients with Alzheimer's disease may also have loss of neurons. They have amyloid deposit in the wall of the small vessels. Okay, patient may have no bodies. Okay, these are the eosinophilic rod sac intracellular structures. Okay. So this is all for today. Okay, so in Alzheimer's disease, I'll again show one slide. Okay, so in morphology microscopy, you should write the neuritic plaques, neurofibrillary triangles, severe neuronal loss, and reactive glycosis. Okay, so in grossly, you see the widened sulci. Okay, and this thing. Okay, so the signs of Alzheimer's disease, that is very essential to diagnose as a Alzheimer's disease. होइन पेसेन्टको के तिमीहरूले ब्रेनको त बाइप्सी लिएर we don't look for the plaques नि त होइन So yes, signs of Alzheimer's disease is very important. Patient may have initial phase में signs कुराको memory loss हुन्छ, आफ्नो daily activities गर्न सक्दैन, जुन पहिला गरिराख्ने कुरा गर्न सक्दैन. Date of birth, anniversary, let's say, special member हैन बिर्सिँदै जान्छ. In the later stage, he has a problem with so many things. Time थाहा हुँदैन, place थाहा हुँदैन, later stage पेशेन्टले आफ्नो घर थाहा हुँदैन, family members चिन्दैन, त्यतिमा नचिनेर मात्र हुँदैन, त्यसले आफ्नो daily खाना खान आउँदैन, खाना they have a problem with so many things. They have a problem with their movements. They will become mute, बोल्न आउँदैन. Okay, so so they will have so many problems. अनि के हुन्छ, withdrawal from the society, withdrawal from the family member.